Welcome to NAU DPT. Do you have cervical spondylosis? Come on in.
Cervical spondylosis. What is it? It's a degenerative disc disease affecting neck due to normal age-related wear and tear. So cervical being the neck and spondylosis being arthritis is basically just arthritis of the neck. So it's when the soft vertebral discs that provide cushion become dehydrated, shrink, and become compressed. So when compressed, more stress is placed on the facets, which can cause movement between the vertebral segments. As they rub, bone spurs may form. Alright, so what are the effects of cervical spondylosis? It's when spinal nerves have less room to pass through the intervertebral foramen, leading to impingement, causing pain. So some symptoms are grinding sensation when moving the neck, weakness, numbness in arms, hands, and legs, headaches. Once it becomes more severe, you can have pain radiating into the shoulders and arms, and difficulty maintaining balance. Cervical spondylosis usually doesn't lead to disability, but sometimes the spinal cord nerves and roots attached to the segment become compressed and can cause legs and hands to feel weak, numb, or clumsy. So basically you lose fine motor skills. Once it becomes severe, it's also termed cervical spondylitic myelopathy.
Okay.
And
Action! Let's talk about prognosis. We have two options for treatment: conservative management or surgical intervention. When it comes to conservative management, we have lots of uncertainty. There's not a lot of research in the field. We don't really know. It is, though, considered safe for patients with mild to moderate symptoms, and it can be seen as preventative, as well as keeping patient status stable. Patients with severe symptoms and impairments, though, are typically referred to get surgical intervention. However, conservative management could include low-risk exercise, isometrics, using NSAIDs, ice and heat, as well as muscle relaxants or spinal epidurals. When it comes to surgical intervention, the earlier we have intervention, the better the results will be. Patients over 80 years old are unlikely to have a full recovery. However, 75% of patients who had symptoms for less than a year had better surgical outcomes. And then 78% of patients who showed symptoms for over 2 years actually showed signs of worsened state and or maintenance of their current state. And then moral of the story, it truly depends on the patient, and we have to view each patient individually for the best outcomes.
Okay, so first, isometrics are one of the exercises in our intervention plan. As we know, in osteoarthritis, shear forces on the spine can both cause this condition as well as irritate and aggravate those symptoms. So that is one of the exercises that we've decided to include in the intervention plan are self-resisted neck isometrics. All right, so as we talked about, we're going to be including isometric exercise in our program. And I talked about how shear forces can contribute to the pain. We're going to strengthen the surrounding musculature of the neck to distribute those forces. All right, so this is super easy because you don't need any equipment at all. Jack, I just want you to take your right hand, place it on the right side of your head, and push into your hand. Good, and let's do that for a 10-second count. And then we'll go to the left side, left hand, push into it. Good, and we're just gonna repeat these isometrics all the way around the head. So then we'll go 2 on our forehead here. Well, remove the hat, please. Press into the forehead here, good. Same thing behind your head. Good, and lastly, we're gonna work on rotation. So take your right fist, put it in your cheek right here, and then try to rotate into it. And resist the rotation. Left side. Good. So we would do a 10-second count for each of these, and Jack could repeat this several times a day. We're just trying to strengthen the muscles of the neck.
So the chin tucks are going to target the deep neck flexors, Y raises are going to target the lower trap, and then serratus punches are going to target the serratus anterior. Okay, so the next thing we're gonna do is chin tucks. So these are gonna target the deep neck flexors in Jack's neck. So Jack, can I have you lay supine for me? And I'm just gonna place this towel right under his head. Perfect. Okay, and then once you have the towel under the patient's neck, just ask them to bring their chin directly into the table. So Jack, can I have you just bring your chin down? Perfect. And then you're just gonna tell them to hold for 10 seconds, and we'll do 1 set of 10 of these. Okay, and then with the Y raises, these are gonna target Jack's lower traps. So we're gonna use a band for this, and Grant is gonna hold it while I demonstrate. So you'll have somebody holding it in the middle of the band right here. Your patient is gonna take it into their hands, and they're gonna lift up in a Y. Just like that. Perfect. And then with these, you could also just watch that their neck is in neutral, which Jack's is. And then we would probably do reps of 8 to 10, maybe 2 to 3 sets. And then for the serratus punches, we're gonna have Jack lay on the table again. And then with these, to target the serratus, they're gonna have their arms straight up in the air above them. And you're gonna instruct them just to punch the ceiling like that. Perfect, and then back down. If they're doing good with that, you could add dumbbells. And then push up. Perfect. We would also do 8 to 10 reps and 2 to 3 sets. And then we also have nerve glides because cervical spondylosis causes impingement. So we could do nerve glides to kind of stretch the nerve out.
Next in our intervention plan are proprioceptive drills. And there were a lot of interesting proprioceptive drills in the literature that I found, and we'll demonstrate those. But the research shows that in patients with cervical spondylosis, they have impairments with proprioceptive ability. So just being able to help these patients improve their ability in their cervical spine to just know where their head is at in space has been shown to greatly decrease pain. So for our next set of exercises, we have some proprioceptive drills, and these are going to be fun, Jack. All right. So what we need is a laser pointer on Jack's head. Oh, sweet. Perfect. Okay, yeah, that'll do. So our first drill, Jack, I'm going to have you actually, Jack, can you sit on this side of the table or on the other side of the table? So in Jack's pain-free range of motion, we're going to be working on just some rotation. So Jack's goal is to trace my laser pointer as accurately as he can. Like I said, in his pain-free range of motion, we would do this 10 times each way. Good. We do this 10 times each way and give the patient ample rest as they need. But this, like I said, this is working on their proprioceptive abilities. So for the next proprioceptive drill, we're going to be seeing how accurately Jack can trace a shape. Okay, so Jack, I want you to, as accurately and as quickly as you can, trace this heart here, okay? And we're going to do that 10 times. Nice job. Oh. Good. So, like I said, we would do this, we would see how quickly he can do this. This is a good retest measure for the patient, and improving their proprioceptive abilities in their cervical spine has been shown to decrease pain. Next, we were thinking in our intervention plan that perhaps a lack of mobility in the thoracic spine could contribute to this hypermobility in the cervical spine. So we thought thoracic spine mobility exercises would be a good thing to add in.
And then in other research that we did, specifically looking at decreasing pain in those with cervical spondylosis, we found that cervical traction and cervical manipulations can decrease pain. cervical tractions, they would have it on the patient for like 8 to 15-minute sessions, and then they would do that once per session each time they came to PT.
So for the early stages of cervical spondylosis, we mostly use patient-reported outcome measures, like the visual analog scale, which is your basic 1 to 10 scale, measuring pain, 1 being little pain, 10 being very intense pain. Or we can use the short form 36, which uses several descriptive words such as throbbing, shooting, stabbing pain, and grades each one of those 0 to 3, 0 being mild, 3 being severe. We could also use the Neck Disability Index, which asks 10 questions about ADLs and grades each 1 to 5 based on how difficult it is, total score out of 50, 0 to 4 being no disability, 5 to 14 being mild disability, 15 to 24 being moderate disability, 25 to 34 is severe, and anything above that is complete disability. In advanced cases of spondylosis, we may have myelopathy, which then we'll use some different outcome measures. The first being the Japanese Orthopedic Association Cervical Myelopathy Evaluation Questionnaire. That is a 4-part questionnaire that is graded out of 17. A score of 15 to 17 is mild disability. A score of 12 to 14 is moderate, and anything below that is severe. Lastly, we can use the NERIC classification score, which is a 0 to 5 grading scale. 0 is root symptoms or no symptoms at all. A 1 being a mild signs of spinal cord compression. 2 is gait difficulties, but they have no issues with their job or ADLs. A 3 is gait difficulties that could cause issues with their employment or in their ADLs. 4 is unable to walk without assistance, and a 5 is completely wheelchair bound.
Alright guys,